All right, so I think the whole day address issues on when do we stop. And I'm going to start big and I'm going to end up small in terms of endpoints of CLI. So you see here that these are all clinical endpoints. Some of them very, very important are patient-related. Some of them are wound-related. Some of them are infection control. Some of them are limb preservation, some ischemic-related, and then functional assessment. All these things are legitimate endpoints of these complex patients that we deal with on a daily basis. And I will say that achieving all the endpoints in a single patient is nothing short of a miracle. So these are parameters that have been described in the literature. Traditionally, ischemia is associated with patency, limb amputation-free survival, etc. We all know that actual perfusion and metabolic demands, as long as you have more perfusion than demand, we are okay. And then as you become ulcerated, the metabolic demand goes up, and then eventually your actual perfusion has to overcome that metabolic demand in order to heal. And after that, you do long-term follow-up, and the metabolic demand goes back to baseline, and your healing hopefully stays, and then your patency may go down or may stay up. And again, critical limb ischemia decision-making is complicated. You got all these things that you need to put together in order to actually start deciding, am I going to treat the patient primarily with revascularization? I'm going to amputate this patient. I'm going to palliate the patient. I'm going to conservative this patient. And all that has been published, and we do it on a daily basis screening. Once we select to actually revascularize the patient, there is a lot of things that we need to do in terms of evaluating perfusion, and that should give us etiology of the non-healing wounds, identify the patients who might actually benefit for immediate revascularization. We've written about deferred revascularization in the conservative subgroups, select the target vessel that we're going to revascularize, and inside when revascularization is sufficient, which is the overwhelming theme of today, and then facilitate surveillance after you're done with your procedure. So we talk about this morning throughout the burden of the disease is changing. The big arteries then became small arteries, and now the MAC, which is a combination between the two. So the patients are actually getting more complicated to achieve those endpoints. So we need more tools. But I will say that we all agree that limb preservation with complete wound healing should be the #1 endpoint of what we do. And we started with the angiosomic concept and kind of proven a little bit that direct revascularization is superior in terms of predicting wound healing rates compared to indirect, but nevertheless, that is not feasible in every patient. So, intraoperative perfusion evaluation should allow us to direct the target and extent of revascularization efforts, like George was saying this morning, when to stop. And there are a lot of tools that are being used, and some of them validated, some of them not so much. There are physiologic tools, skin perfusion-based, external or implantable, image-based, angiography or duplex. These are the three modalities: physiologic, skin, perfusion, and image-based. Physiologic is really not reliable, and we all know why. The physiology and the anatomy of the patients are changing, so calcinosis, small artery disease are simply non-detectable for ABIs in general. And there's no correlation between ABIs or TBIs and on wound healing. Now, skin perfusion, there is a lot of data on the field. TCPO2s, which oxygen tension, SPPs, NIRS, speckle, thermometry, and internal, the implantable devices. TCPO2 is an electrode sensor that is placed under the skin and measures O2 pressure. There is significant literature associated with that, and you've seen that in the DVA this morning as TCPO2s go up over time. And we study this as well, and a kind of 2 weeks, if we can, stage from revascularization to actual podiatry procedure to allow an increase in the perfusion of that particular region. So it's been validated. Skin perfusion also has been validated, and a predictive value is established at the 30 millimeters of mercury as well. It's a laser probe around the inside, the pressure cuff, and detects blood flow. When the cuff is deflated, the returning flow. You have NIRS, which is something that the snapshot camera, which you take from 12 inches, you have spectral perfusion and allows hemodynamic regional measurements and microvascular tissue oxygenation. No predictive value is established yet. It's being studied as we speak. And again, allows pre-procedure, intra-procedure, and maybe post-procedure changes, but there's no predictability yet. Another example of speckle laser is PEDRA, received FDA 510K a year ago, I think, and again assesses real-time per channels the foot perfusion, and you can do that intraoperatively as well. And you can see here some examples of that. Again, not validated in trials. Medtronic, and I know Sinai is part of that trial, among other institutions, have the FlowMed device, which is, again, an intraoperative sensor that allows you to dial flow. And whether this can relate with I can be done with my procedure or not, I'm going to meet that. That has not been validated as well. All these things are externally. Then we have the image basis, angiography, the angiography blush, as we described this morning, as one of the big things that we want to see. And definitely it's been noted and correlated, particularly in the Japanese literature, to wound healing. The problem is it's a little bit subjective, but it certainly correlates with wound healing as well. And, not always you see it. And if you don't see it, you keep doing things until you see it. You inject more contrast so you can get that blush. You don't. There's a lot of things that I think are a little bit subjective. 2D perfusion, again, no predictive value. A software analysis that measures contrast delivery to a region in the post-processing of the standard angiogram itself. Promising, but not really validated. Indocyanine, green fluorescent, is the IV administration. That binds with plasma proteins and allows visualization of the regional flow again. Again, no predictive value. It's been yet proven. And fractional flow reserve, which is really what you guys do in the coronaries all the time. Japanese actually rely on this quite heavily and seems to have a good correlation with wound healing and their literature. And each of these things is a talk on their own, by the way. So one thing that has been mentioned this morning by Dr. Fisher here is pedal acceleration time, and certainly there are 4 different classes of pedal acceleration time, something that the previous operator had an ultrasonographer at the bedside doing things, and I was hoping she would be actually measuring that since they're doing a critical limb ischemic patient. But nevertheless, and you have these 4 different classes, and these slides come from actually Jill Somerset, who was very kind to share with me. And you have these 4 different classes. It will move these patients from pre-procedure to post-procedure. 2 classes, actually there's a correlation in their paper of wound healing rate, and you can see there. There is also a correlation with ABIs increase at the end. So that is another thing that it's coming our way, or it's being used actively in some institutions already. So you can see there that all those patients who went to limb salvage and wound healing had a correlation with 2-class improvement on PAT versus patients who did not, and they became simply ischemic and with poor limb preservation outcome. And they are using it now. This is Miguel Montero doing a venous arterialization as well, and they're using that as a predictor of, okay, am I done with the valves? Am I okay? The flow is initial flow. What are we learning? There's a lot, like Tizi said this morning. I mean, we're learning a lot about endpoints. We really don't have that answer. So current investments in developing of intraoperative endpoints are crucial to our ability to marshal our resources and possibly compare therapeutic effectiveness in a level that we haven't done before. Thank you very much.